co-occurring substance use disorders and mental illness. And this is just a review of this topic. I'm actually presenting on behalf of Dr. Bott. I don't have any disclosures related to this. We're hoping that by the end of this didactic that you're able to differentiate between substance-induced disorders versus independent psychiatric illnesses and sort of be able to delineate between those things. Learn sort of the prevalence rates of the comorbidity between substance use disorders and the various psychiatric illnesses that tend to go along. And then construct a treatment approach for what is sort of best practice recommendations related to patients with opioid use disorder who may fall into this comorbid or dual category. So let's start by going through some definitions and incidence rates. So this data comes from, which outlines, I think, sort of the incidence of past substance use disorder and mental illness amongst adults. And you can see that, that there is overlap here, that there's around 10 million that would fall into the category of meeting criteria for a substance use disorder, but nothing else. And then on the other side, about 36 million that meet criteria for a mental illness, which we know could be any number of things, but no substance use disorder. And then we have an overlap in the middle of about 8 million individuals who would meet criteria for both. So this is a fairly large number of individuals. This one is looking at, this one is mental illness, and then this one is looking at serious mental illness, so what would qualify as an SMI diagnosis. And so those tend to be, you know, things like schizophrenia or bipolar, PTSD would fall into this category of serious mental illness, so they tend to, smaller incidence, but yet there is still overlap, right? So we can see there's larger percentage in that with substance use disorder versus SMI, but then about 2.6 million will have that overlap. So something to consider for individuals who are working primarily in a substance use disorder specialty setting, that we want to always be assessing for both, and then vice versa. If we're working in a community mental health setting, we also want to be assessing for the possible prevalence of substance use disorder, because we know that there is an overlap, that substance use disorder can increase the likelihood of developing, and this is calling it Axis 1, so we're thinking non-personality disorder conditions. So that substance use can actually increase the likelihood of developing one of those conditions, and then vice versa, that if you already have a mental health condition, like those symptoms could increase the likelihood that you will go on to develop a substance use disorder. So sort of that chicken or egg situation, that these things can be related. And the same thing is true for severe mental illness. So we know that individuals that fall in that category, so subjects with a substance use disorder, show a 4.5 times greater risk of developing a co-occurring severe mental illness or psychiatric condition. And then subjects with a psychiatric disorder show 4.5 times greater likelihood of suffering from a substance use disorder. So these things hang together very closely, particularly when we're looking at psychotic conditions, schizophrenia, and then affective conditions. So anxiety disorders or mood disorders tend to be most prevalent. And there's a bunch of different theories about why these kind of hang together. There's shared genetic contribution. There's shared, we think, stress-related vulnerabilities with these conditions. So this was a study that looked at almost 500,000 people and broke down the prevalence rates of individuals with a lifetime substance use disorder. So they make criteria for a lifetime SUD, and then what were the co-occurring conditions. And so you can see higher incidence rates of schizophrenia and schizotypal disorder, as well as other psychoses. So individuals that have sort of those psychotic conditions, higher incidence rates of them, followed by bipolar disorder, depression and anxiety condition, and then lower rates of OCD. And then the most commonly abused substance, just like we know nationally, was alcohol. And we, even though we focus primarily in this echo on opiate use disorder, alcohol is still the most prevalently abused substance. So that makes sense, it would be found in this study. So they also found that patients with substance use disorders, lifetime prevalence rates tend to be more often men, have had fewer formal years of education, and more often received a disability designation or funding for that, and then will higher rates of dying due to unnatural causes that could be associated with either of these co-occurring conditions. Here are some of the consequences that are associated with being duly diagnosed, so being having a DD diagnosis, compared with just having SMI or SUD alone. So those people that fall in the middle of that Venn diagram have particular vulnerabilities, more likely to end up with psychiatric hospitalization, higher likelihood of their psychiatric condition relapsing, higher number of suicide attempts, violent behavior, aggressive behavior, criminality or involvement in criminal behaviors, more likely to end up imprisoned, have family problems, of course, because of some of the things we've already stated, obviously some loss of social status or poor social connectedness, low rates of quality of life or poor quality of life, having a much greater likelihood of medical comorbidities. So because of those conditions, they can cause a whole host of medical comorbidities, HIV infection being one of them, higher rates of unemployment, homelessness, poor treatment adherence, and then what would result in therapeutic failure. So this is a population that we really want to make sure that we're assessing for and intervening effectively with, because they obviously have a list of negative consequences associated with having dual diagnosis. So let's talk about how you begin to assess for this population of patients. So if you're working with someone that comes in intoxicated, there are a couple steps that are recommended. We absolutely want to be screening for suicidality and homicidality at every encounter, review their vital signs to make sure that they're stable physically, attend to any medical symptoms, or make sure that we prioritize withdrawal management because they're coming in intoxicated, which means they could go into an associated withdrawal. You don't, when someone is intoxicated, do you want to go into a psychiatric evaluation? That being said, you want to wait until they've cleared and they're in a more rational state before you ask some of those questions, because obviously they're going to be more likely to be in an emotional state or act impulsively, and we don't want to trigger some of that stuff when they can't contain it or we can't help them contain it effectively. So then, assuming that you can proceed with someone that is in a state where we can conduct a thorough evaluation, we want to be thinking through the difference between substance-induced disorders versus an independent psychiatric disorder, which is going to sort of be a co-disorder with that. So it's a substance-induced disorder is related specifically to the psychoactive substance itself. It could, the symptoms, the mental health symptoms or the psychiatric symptoms that you might be observing or that the patient is reporting will typically remit with sustained abstinence. This is true with things like psychosis-induced methamphetamine use, right? So we can see that typically once that substance is cleared and they've maintained abstinence for a period of time, we will see some of those psychotic symptoms remit. The same thing with, we can see patients that will come in with long-term alcohol use that might have a lot of depressive symptoms, but it might not be an independent depression. It's something that is really being induced by the routine use of a depressant like alcohol. That's versus an independent disorder, which you will be able to determine, do the symptoms exist during times of abstinence? Do the symptoms continue even with sustained abstinence? And so they sort of exist without the substance being in the system regularly. There's really no specific period of time which allows us to differentiate these disorders. one of the recommendations for doing an assessment like this is to really do a thorough timeline of their problematic symptoms. So what they're coming in and telling you, both their substance use symptoms and any mental health or mental illness symptoms that they're reporting, to get an idea of duration, frequency, date of onset. So we're kind of getting an idea of where does it line up on those independent timelines. To do a thorough assessment of the SUD, or the substance use disorder specifically, you're going to want to make sure that you understand that the symptoms occur only when misusing or abusing that substance. Because remember, substance use in and of itself is not a disorder, that it has to cause functional impairment. So are they using at a level that is causing impairment? What are those symptoms will occur only when using. It's not associated with periods of sobriety. The symptoms are related to either intoxication, withdrawal, or other aspects of active use. And so if you go through the DSM criteria for substance use disorder, it clearly will outline that. And then we want to understand the onset and or offset of symptoms that are preceded by increases or decreases in their use. So you can very clearly see that their functional impairment or the symptoms that they're reporting is linked to or associated with the drug use itself. What we're wanting to do in terms of when we move into treatment is helping them, and I know we've talked about this with harm reduction, but think about how can they decrease their use to move in the direction of abstinence or sobriety, or at least decreasing their use to more functional levels, and then regularly reevaluating where their use is at. Conversely, when we're looking for independent disorders, so this would be a psychiatric condition that we're saying is potentially independent from the substance use disorder. That's where we're looking to identify that the symptoms are occurring when they're not using a psychoactive substance or a drug, and that it tends to be steady over the course. So without any change in amount or type. We also can link this with family history to point to an independent disorder, or especially if it's in a first-degree relative. So we know, for instance, a lot of the psychotic conditions will have a heavy genetic relationship. So we can usually see an instance of those conditions somewhere in the close family system. And that you see those symptoms will continue even once they've attained sustained sobriety. So that's sort of some of how we're starting to rule in that this is an independent disorder. And what we're looking for to treat that, of course, is to help them, in addition to decreasing their use behavior, but really to also treat the co-occurring psychiatric symptoms. So some of the things you always want to include in your assessment include making sure that you're getting a thorough history, both of the substance and their psychiatric symptoms, family history, initial onset of symptoms. So again, you want to look for initial onset, frequency, and duration, severity of those symptoms. And then what is present during periods of abstinence. And so that's why it's really helpful to use a timeline structure with collecting this information. And then we sort of treat based on our best hypothesis if this is a dual condition, and we observe what happens. So this is a table that's breaking down the primary mental disorder versus a substance-induced disorder, and sort of helps you to sort of look at those things that we just talked about. So this is a helpful table to keep on hand for a differential, looking at the clinical characteristics between a primary or independent disorder versus a substance-induced disorder, which can have a whole host of psychological symptoms connected with it. So I'm not going to read through the table because you guys will get the slides, but recommend keeping this on hand. So in terms of assessing from a medical model, and I don't know if this is something, Dr. Jacobsohn, you had thoughts you wanted to jump in with, because this isn't necessarily the information that's going to come from the DSM to diagnose a SUD.
Yeah, thanks so much, Dr. Maley, for presenting. And So for the two states of intoxication and withdrawal, basically what you're seeing here in the red for alcohol intoxication with the mood lability, inappropriate or aggressive behavior, impaired judgment, impaired attention, impaired functioning, that you might see, you know, in if there's co-occurring diagnoses going on, right? So you may not necessarily be able to pull apart the actual physical intoxication from perhaps other underlying mood disorder. But the blue that you see with slurred speech, incoordination, unsteady gait, nystagmus, impaired memory, stupor, coma, these are things that are concerning for that level of intoxication alone. I believe that is what Dr. Bott was getting at with this distinguishing those colors for intoxication. Then with the state of withdrawal, same thing. With the red, you might think that these things could be related to the withdrawal, but perhaps also to the co-occurring psychiatric oh, sorry, I'm getting an error message on my screen. I hope I'm not about to be. Okay, sorry. So anxiety, insomnia, agitation, auditory hallucinations, you may see with both, right? But with just the withdrawal alone, we would expect to see those physical signs of autonomic hyperreactivity, the tremor, nausea, vomiting. And then visual or tactile hallucinations, we don't tend to see with things like an underlying schizophrenia, but might see from, say, withdrawal from a substance alone. So that aspect of hallucination, seizures and delirium. So that's kind of a way to sort of distinguish those two states that can happen, again, with the red ones in both conditions, dual diagnosis conditions, and the blue from purely the substance. And I don't know if you wanted to add anything to that, Dr. Maley. Okay.
That was great. So do you want to?
Oh, yes. So here we've got, sorry, this changed to, okay, the stimulant slide from alcohol, cocaine, or amphetamine. Yeah. So again, here we look at the comparison between intoxication and withdrawal. And so intoxication with the stimulant, we would expect we might see anxiety, anger, but again, like the red is looking at things that could happen with the dual diagnosis state: psychomotor agitation, weight loss, euphoria, increased sociability, hypervigilance, anger, impaired judgment, impaired functioning, agitation, again, those auditory hallucinations or paranoia. But we wouldn't expect to see in the blue that from the underlying mood disorder, but simply from intoxication alone. So vital sign abnormalities, all of the physical signs that we can get from intoxication, chills, nausea, cardiac symptoms, confusion. I think that at times that might also come in line with some of the dual diagnoses, but I think that's getting more at like the actual effect of the intoxicated state from stimulants, coma, seizures, visual or tactile hallucinations would be different from the auditory that we could also see with underlying mood disorder. And then withdrawal. We see these symptoms, withdrawal from stimulants of fatigue, insomnia, hypersomnia, increased appetite, psychomotor agitation or retardation, vivid or unpleasant dreams. And again, we can see that as well in the co-occurring state. And then cannabis for intoxication. Again, for co-occurring, we can see social withdrawal, anxiety, paranoia, euphoria, impaired judgment, but then we would expect to just see those physical signs from intoxication alone in blue, so the impaired coordination, conjunctival injection, and tachycardia. And then the withdrawal state from cannabis, again, we can see in the dual diagnoses, the depressed mood, irritability, anxiety, insomnia, decreased appetite or restlessness. But from the actual withdrawal state alone, would see strange dreams, headaches, the shaking, sweating, other physical signs, stomach upset. And it goes on, opioids. So in the intoxication state, with the combined dual diagnoses, we can see that apathy, dysphoria, or euphoria, agitation, impaired judgment, but then the physical signs alone would be attributed to the actual intoxication of opioids, not the dual diagnosis, so the meiosis, slurred speech, drowsiness, respiratory depression, or coma. And then the withdrawal state, again, could be seen with both dual diagnoses, so dysphoria, irritability, anxiety, insomnia, and fatigue. But then we would expect from purely the opioid withdrawal alone, the blue section there. So again, the physical signs ranging from nausea through body aches, fever, yawning. Yes. And for nicotine, really we have just the withdrawal grouped here, and that can also mimic some underlying mood disorders, so the dysphoria, irritability, anxiety, restlessness, poor concentration, but really just bradycardia alone would be the physical sign due to nicotine withdrawal.
Thank you so much, Dr. Jacobsohn.
Yeah, sorry.
And then for non-medical providers, your tool to use for diagnosing substance use disorder would of course be the DSM, and looking through that diagnostic criteria for each substance type. Okay, so now let's move on to treatment considerations. And I really like his analogy here, because I think it's very appropriate that when working with, once you've assessed and you've determined that this individual it has comorbid mental illness and substance use disorder, so they fall into that dual category, you really need to treat both conditions concurrently, because it's like having two holes in a ship. And you can plug one, but you still have a hole. So you're still going to sink at the end of the day. And I think that's really an important thing to consider, especially when we take into account the history of substance use disorder treatment. It is unfortunately still very much with us today, in the sense that substance use disorder specialty services tend to be separated from general or community mental health services. And so patients in this category, they end up sort of being shifted from one clinic to the next, where they go to their substance use disorder provider or clinic, and they're told, well, we won't treat your mental health condition. We will only work on your substance use disorder. And if they go to the mental health treatment provider or setting, they're told, well, we won't treat your mental health condition until you've achieved sustained sobriety. And so unfortunately, these individuals get sort of in this catch-22 where they're passed between providers, which ideally, you know, we're wanting to treat both in the same location with the same provider, because they're going to be much better to do it concurrently or simultaneously rather than in sequence. Because they are so related, it was previously thought that before you could treat a mental health condition for someone in the dual category, that they had to have 6 months of sobriety, and then that was revised to 1 month of sobriety. Well, for those of us that work with these folks, you know, it's often quite difficult to get 1 month of sobriety, because oftentimes the mental health symptoms are triggering the use disorder, and vice versa, and so they're sort of exacerbating each other. And if we can just treat them simultaneously, we're going to get much better results. So sort of recognizing that they go hand in hand, and that we can treat both at the same time. And so this is just another reminder of what I said earlier, that substance use alone does not equal a substance use disorder. So we need to make sure that when we're taking this approach, that the person is assessed to have both a substance use disorder and a psychiatric condition, and that they meet diagnostic criteria for both, and that we're not focusing on someone who has occasional use or does use substances, but may not use it at the rate where they are having functional impairment related to their use. So our recommended approaches to treating this population, step one, or the first line of defense, is psychotherapy or psychosocial interventions. So considering as the first line of treatment to deal with both the use disorder and the mental illness is to use a psychotherapeutic approach. especially those that are reporting less severe mental illness. So less severe depression or anxiety, or PTSD, sort of the things that are falling in those categories. If it's less severe, then we really can use psychotherapy to effectively treat both conditions without necessarily needing to go into a psychotherapeutic stance. Now, that being said, if someone has very severe symptoms or has a condition that we know is going to require a medication, such as schizophrenia or bipolar disorder, then we would want to take both of these steps at the same time. That we would want to include psychotherapy and psychopharm on the same table. But if it's less severe, their mental illness is less severe, then we can usually approach it with just psychotherapy. In general, depressive and anxiety symptoms are very common, especially at the entry to treatment for most substance use disorders. That doesn't necessarily mean that they will meet criteria for a depressive or an anxiety condition once their substance use has resolved. So we're not necessarily going to approach it as we want to treat the depression and anxiety the same way as we would if it was a standalone condition. But just recognize that that's fairly normative with people that are coming into treatment, because the substance use disorder can just wreak havoc on their social connectedness, on how their brain and their body is functioning. It's really common to see sort of low mood and anxiety symptoms coming into treatment, and especially as they're decreasing their use. The symptoms may resolve within a few days to a few weeks of just stable treatment. We don't necessarily need to directly treat the depression or the anxiety. Symptoms that persist beyond intoxication and withdrawal phase, right, sort of in that window, then we would want to include them as targets for treatment and would want to consider a recommended therapeutic and psychotherapeutic interventions for those mental health conditions. We know that patients that are treated with medication-assisted approaches respond to medications for depression and anxiety at the same rates as those without opiate use disorder. So we know that it's a good line of approach for OUD patients. But we do want to avoid addictive medications when possible. So prescribing things like benzodiazepines or stimulants, and then make sure that we do a lot of careful monitoring. So this is the list of, or at least a brief list of medications that are recommended for primary care providers by condition. And so you can see that these are typical medications recommended, but without the benzodiazepine. Is there anything you wanted to add, Dr. Jacobsohn?
No, thanks. I think that's perfect. A lot of these medications that are most evidence-based for these conditions are going to be, as you can see there, in the SSRI and SNRI category, until you get down further along the list. With PTSD, there's growing evidence that the addition of prazosin may be helpful to that SSRI. And valproate's listed there in addition for bipolar disorder. Thank you.
Okay, so just in terms of looking at some more aggregate data, looking at who is receiving services. So this is breaking down the difference between individuals that meet criteria for substance use disorder and a co-occurring mental illness. And you can see that the majority are receiving no treatment. So 51% are receiving no treatment. The next largest category are in the mental health service only. So they're just getting treatment for their depression or anxiety or PTSD and not receiving treatment for their substance use disorder. A much smaller percentage are just getting SUD treatment only. And then 6.9% are receiving treatment for both. So this is kind of scary in the sense that only 4 years ago, when they collected this data, that we're really not following as a community nationwide. We're not following best practice, which is to treat both conditions concurrently. And then the same sort of similar data for those that fall into the SMI category. So we see that again, the thank goodness, the majority is receiving treatment, but they're falling in the mental health treatment service only, and that an even smaller percentage is receiving substance use only. And then 12% are getting co-treatment for both their SMI and their substance use disorder. So this is just something to keep in mind. I think it speaks to the fact that our history very much has separated these two areas, when really they should be integrated as their recommendation, or co-located rather than being across town from each other. So I think that that's an important thing to think about as administrators, because SAMHSA's best practice is to really say we should be taking an integrated approach. So with working with this population, we want to be collaborating across disciplines. We want to be sharing patient goals with the multiple disciplines that are recommended to work with an individual with mental illness and substance use disorder. And that our treatment, when it is integrated, when we are working together to treat both of these conditions, rather than doing something that is sequential, that we're going to have reduction in substance use, improvement in psychiatric symptoms and functioning, decreases in hospitalization, increases in housing stability, less involvement in criminality or fewer arrests, and global improvement in quality of life. And so I think that the data is very clear that this is the model or the approach that we should really be striving towards. Okay, so that's all we have for this presentation. I don't think we have a case